Good afternoon and welcome. Thank you for joining us today for our training, Person Centered Care in Nursing Facilities, How to Make It Work, hosted by the Center of Excellence for Behavioral Health in Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence. I am happy to introduce our presenter for today, Ms. Diana Padilla. Diana has more than 24 years of experience in the behavioral health industry. Her vast experience includes service provision to diverse communities with substance use, HIV, HCV, trauma and stress, and other psychosocial conditions. Currently, Diana is a senior staff trainer for the Northeast and Caribbean Addiction Technology Transfer Center. And now I'll turn it over to Diana to begin the presentation.
Hello, everyone, and thank you, Nikki. And thank you, Michelle, and thank you all for being here today. And so here is the title. Here's something I would love to start with. So what's meaningful to our patient trumps anything medical that we can offer. Now, this quote has been referenced quite a few times. This is Dr. Sakaris, an oncologist out of a clinic in Cleveland. And the point of his statement had to do with an interaction he was having with a person he was treating for leukemia. And so even in extreme cases, he notes that one, as physicians and nurses, CNAs and other nursing home staff residents, you folks can actually have an extra impact on that interaction with that resident simply by just involving them in their own process. And so even in the most extreme cases, the impact that can have on a resident engagement and participating, committing to the healthcare plan can really be essential to successful health outcomes for them. And so as we go forward, this is one of the reasons why we want to speak about person-centered care. So noting that in the nursing-centered location or in the structural and a structural environment that has protocols and procedures all tailored to provide services that meet the medical needs and the rehabilitation needs of the resident. Nursing home facilities are such a critical and essential community resource. And so whether the services are provided internally or externally within the community, it is that nursing home care that meets those needs. But one of the things that we want to express is that person-centered care is not just the clinical supports that you provide and not just the services that are tailored according to the diagnosis, the health needs, and the capacities and limitations of the individual. Is person-centered care is also an approach that staff can use in a host of different ways to engage residents in very sensitive situations with sensitive topics. Some of them include engaging them around family support, sometimes lack of family support, sometimes health-related issues that are not necessarily the ones that are part of the care plan, may be a sensitive issue that you can't approach them through a person-centered approach. And another sensitive issue is substance use. And when folks are using, particularly in the residents in the nursing home facility, may be using substances, being able to use an approach that is empathetic, that is respectful of their perspectives, and being able to just to have a conversation. Just a conversation that someone feels comfortable enough to be responsive to you, and they can even participate in the decision-making processes, can actually help, not just into considering how their behavior or maybe augmenting the risks with their health issues, but also in being able to consider some recovery and treatment supports, possibly around their substance use. And so the current landscape of the nursing home residential care. And so what we want to note is, like, you do provide your facilities do provide comprehensive therapeutic and rehabilitative care. It's very it's essential for meeting the specific acute or long-term health conditions of different individuals. It happens that there's so much research and so much data, so many surveys out there. And so I'd like to pull from them, if you don't mind. And so in 2023, and so thinking about what we're currently seeing, amongst long-term nursing home residents, most of them according to the surveys, indicate that more than 83% are 65 years or older. The older cohort in this nation has really expanded and increased in numbers, and we're seeing a lot of those folks be the prominent age group in long-term care. And so we're seeing like 17% or under being less than 65 years of age. And so in your facilities, part of the care that you're giving them can be around just daily functioning issues, like for instance, just eating and preparing meals, or being able to bathe themselves, or being able to dress themselves. Certain health issues or medical conditions may be impacting their ability to go to the restroom on their own, being able to manage their own medications. Even just moving around the residence can be a challenge, and they need your support for that. I also want you to consider that many times this can be especially challenging if they have diabetes, if they also have some eye diseases or cognitive impairment. Um, but there's also some other considerations as well. Sometimes older adults may be in that space where it may be challenging um, to be accepting or come to terms with their limitations, or come to an acceptance of the age-related limitations, and even just accepting help from the nurse or the CNA or the physical therapist. It can be a very challenging thing that folks may be dealing with, and we don't necessarily see that. And that can be part of what's presenting with any given individual that you have in care. And so considering all that, we may also want to think about some of the risk patterns that we see amongst the aging population within residential care. And there's some research that do indicate that Medicare recipients with opioid use disorders, because then we just want to just go right into the substance use related issues. Medicare recipients with opioid use disorders have entered nursing homes at higher rates than they have for a long time. And so those rates compared to non-substance related hospitalizations are starting to increase. Currently, we have 26 versus 22% in the past. And so some of these higher rates that we want to consider, I want to think about how uh, some of these folks are not necessarily aware that some of the substances and some of the medications that they may be using or misusing, it's not necessarily a willful thing. It may be just a fact, maybe something having to do with just the lack of information about tolerance levels in their bodies, age-related issues, and how medications are absorbed, perhaps. And there's more than half of the Medicare recipients, according to one study that I saw, showed or if reflected that about that most Medicare recipients are prescribed 3 to 5 medications, and more than half actually do not adhere to dosage instructions. And so, and this can be for a variety of different reasons. And this is why, and maybe why, according to the CDC, alcohol-related deaths amongst adults increased from 18% from 2019 to 2020. Also, I don't want to be dismissive that the environment can be influencing factors. So that's from the same age cohort, included synthetic opioids, and that increased by 53% between 2019 and 2020. The thing is that when folks are not necessarily aware that as they get older, that their bodies absorb in medications differently than when they may have absorbed it or have taken it, say, when they were 40 years old in much younger times. There are different people that we have met and we have provided care for along the way that we know that sometimes self-prescribe, because when it comes to pain, they already know what works. I've heard people who have to take 3 aspirins and not 2 according to the instructions because they have a higher tolerance because 2 doesn't work. So they take 3. When you're taking 3 and you have gastric issues and you're on medications for other issues, and you're still thinking your body's working as if you were 40 years old, you may be actually causing yourself more damage than not. Now, so for instance, and that's just for instance, and so think about situations like that folks may, because some of the older residents in your nursing care facilities may be of the mind in terms of how they facilitate their own medications. And these are opportunities where nursing staff can actually engage someone in a conversation to provide some information and provide a tailored information and educate on how medications affect an individual, particularly with different medical issues, um, and particularly around age-related issues. And so sometimes the folks in care do not understand that. And so part of what you can do is help educate them on that. One of the other things that can be helpful within the facility for staff, for nurses, for the administrators, for the lead physician, for the CNAs, for everybody who comes into contact with your residents, um, you want to consider about substance use. When how to address substance use? What does it look like? What is it? Well, we know one thing. We know that a substance use disorder has to meet a certain criteria in order for it to be diagnosed as such. We also know that it's really a brain disease. We know that SUD, or substance use disorder, is an array of different types of symptoms, cognitive, behavior, psychological, different types of symptoms that come together in a way that meet the criteria of substance use disorder. It includes using substances despite not wanting to use. It includes using substances despite the consequence of, say, accidents or injury. It can include the consequence of impaired relationships and a few other factors. So just meeting two of an 11-point criteria can actually have someone meet a diagnosis for a substance use disorder. And so, but the challenge here is mostly what we may perceive a person's behavior to be. Many times, what we don't know is the behavioral indicators that might help someone through a conversation that can help a clinician or the lead physician to make a diagnosis of substance use disorder. What it can look like does not necessarily speak to what the science-based process is that actually happens when someone has a substance use disorder. Because when someone is using chronically and using substances chronically, what happens is the neurological processes and then the brain get rewired. They kind of get reformatted. And many times the capacity of the individual is diminished. The capacity for them to not want to use substances is not necessarily within their purview. What happens many times is the brain and the function, the neurological processes are so reformatted that it prompts an individual to seek to continue to use substances. So many times, when a person doesn't even want to use a substance or wants to slow down using a substance, they don't have the capacity to actually follow through on them by themselves without intervention. And so when you think about this is very simplistic the way I said it. When you think about the science-based um, causatory factors of what we may believe we see when we see behaviors, when we observe the behavior of an individual, unless you have that information, many people just go by what they see. And unfortunately, what happens is stigma and shame of addiction has a lot to do with the perception that people may have of somebody who uses substances. And so many times those perceptions can be include that an individual may be willfully causing themselves damage, or maybe in the community that maybe they are immoral, that they are weak. But most of that can be mitigated with information or with education. And so sometimes staff-related barriers um, related to substance use with the resident in care can sometimes incur some perspectives that are inconsistent with substance use as it is defined with science-based perspective, and even how it is diagnosed. So there's been several studies, but this is one study that I thought I'd target. And three themes of the study kind of really concretize what they thought they saw. And so there were some surveys that they did with a cluster, if you will, of certain facilities. And what they identified were three themes. They noticed that there was a lack of staff preparedness, and it had to do with protocols and procedures were not necessarily informed by how substance use may present. And I say substance use as opposed to substance use disorder because the range of use for any given individual can vary. The continuum of substance use, there are different consequences and risk levels that come depending on how often and the amount and the type of substance that a person might use, whether it's extra aspirins while they're on medication, whether it is using more than using a Percocet or hydrocodone pill once every 3 hours as opposed to once every 12 hours as prescribed. So when we consider how some patients, some residents rather, might be using prescriptions or consuming alcohol and not thinking that there would be a contrast with a contraindication to their care plan. So what we want to consider is what type of protocols and organizations are not necessarily equipped or informed by those potential situations that some residents may have. And so it's another thing that was identified was the staff perceptions of addiction. Unfortunately, the lack of information and the lack of maybe some formal training on substance use. You don't have to be a neuroscientist for this, but to understand some of the basics, some of the fundamentals of substance use disorder can help. But some perceptions of some folks who are not uninformed are more likely to perceive it in a more punitive or negative way. And so that can certainly be a barrier to being able to identify and address a potential substance use issue with a resident in care. And then there's overlap of an overall lack of like community resources, and that kind of is actually like a segue and a consequence of staff, the lack of staff preparedness, because if you're not informed about protocols, then you don't really know to take that further and make sure that you have the appropriate resources as needed for any given individual. And so, what we think about when it comes to this is the challenges of addressing substance use. Part of it is understanding how to identify it. And so, and some of it has to do with protocols, and some of it is a combination of all. And so nursing home residents, some may not necessarily be screening their new admissions for substance use, or sometimes they do screen for substance use initially in admissions and don't necessarily conduct or facilitate the substance use screen again throughout their care, which could be just as important. Substance use symptoms in older individuals tend to be misinterpreted as age-related conditions. There are some processes that kind of speak to where age-related, slurred speech and slow movement that may look like it has to do with someone being older, but it's actually more about what can be induced by a particular substance someone's using. What we want to do is let's just eliminate that possibility. Adults with substance use disorder at times may be denied admission to residential nursing home care. The biggest issues that we see is that nursing schools do not necessarily routinely teach about substance use disorders because there's such an implication to different points of care that you nurses and CNAs and physicians provide to residents in care in your facilities that can be so helpful, so augmented by understanding about potential impact of substance use with your client. And so when we have stigma and bias, and that's what can happen from time to time, and I'm looking at the time right now, so I'm just going to go over some information just to kind of keep us aware that sometimes we're influenced by what we see in our environment. When we do not have the appropriate information or education on a particular topic, we're also vulnerable to what our environment kind of tells us. And so sometimes some folks may have some perceptions where may consider that some of the care that they're giving, the certain persons may be more intensive because they have a substance use disorder. Sometimes there's thoughts that the individual may be more manipulative or aggressive or unpredictable, or maybe more deceptive or challenging. And really, it has a lot to do with not understanding how the substances may be impacting someone. And so what I want to do really quick here is ask you something. Everyone that can be in the chat, that is using the chat box right now, I would like you to, if you don't mind, let's do an experiment. And we'll try to do this quickly because I want to try to make a point. And so I am going to bring up a very, very brief statement as a couple of words, and I'm going to ask you to complete the statement with the first word that comes to your mind, and please type it in. So here's what I'm going to say. Night end, please fill in the blank. What word would you put in there? That was very quick, Damien. Thank you. Dave. Of course we would. Very good. Let's do it again. That's excellent. Thank you. How about young and blank? So I like that. Young and restless, young and quick. Most people responded old. Most people responded, thank you everyone for participating. So here's what I wanted to make a point of. even unconsciously, we are more prone to automatic reactions or automatic responses, if you will. And it has to do with what we've been conditioned to thinking. We know that night and day have come together for a long time. We've heard it over and over again in different contexts and different conversations for different topics. And we can say the same about young and old. Yet most of you responded almost the same way. And so that same conditioning happens subconsciously. And sometimes when it comes to substance use, that's what we end up thinking. When we don't have the ability to mitigate those automatic reactions with actual education and training, formal training on substance use, we can have um, biased perceptions of anybody who uses the substance, and only because we don't have that information. And so that's where I see a real good opportunity, a real healthy opportunity for you folks to be more informed, because there are times where practitioners who from different behavioral health fields and treatment fields have come together and have actually considered a more punitive perspective for somebody who is considered a substance abuser as opposed to someone who has a substance use disorder. The idea here is that there's negative connotations with people who use substances, and we want to get past all that. And so what we want to do is talk about person-centered care in a different way. The reality is that all moments of human decision making are susceptible to the influence of implicit bias, whether it's positive and negative. And these biases can have grave effects on all outcomes in all sectors of society. And for what purposes, we're talking specific to the care, all that energy, all that time that you invest in ensuring that the services are meeting the needs of any given individual in your facility. And so from that perspective, we consider how the unconscious mind kind of just grabs information, makes a decision in that moment. Like if you're in the middle of the street and the light changes red and all of a sudden you're in the middle of a walkway and the car's coming towards you, you don't have time to think of the pros and cons and let's say, okay, if I stay here, I'll get hurt. If I don't stay here, you don't have that kind of time. Your mind is developed in such a way to make decisions immediately to help you survive. The idea here is those processes kind of get caught up and get influenced by our environment. And sometimes we absorb the very things that don't speak to who we are. And so what I want to make the point of is sometimes our biases, if they were learned, even unconsciously, once we're aware of them, we can unlearn them. And so we can recognize how to identify our biases. We can understand that we're all malleable creatures and we all may have them. But the fascinating thing about raising your awareness is that once you are aware that certain things can influence, that you have a certain belief system, you're able to put it on the side and more likely to be able to actually engage in a conversation with an individual and see things and elicit information from them and understand how they see certain things in their life. So cultural humility is a way to mitigate that. It's more than a concept. It's really about an other person orientation. Humility really means, it doesn't mean that you're not proficient at what you do. It's really about that you understand you don't necessarily know everything about everyone and what's moving and pulling and pushing them in different ways and what they may be thinking, what may be influencing how they behave. And so the culture really is, and this applies to anyone who believes, who has philosophies and culture and belief system, values, and certain traditional ways of doing things, anyone can certainly be looked at from a cultural perspective. So cultural humility is that process that as a strategy can be helpful for person-centered care. It's a way of making sure that we are always seeking to learn from the other individual, a way of ensuring that we elicit information from the other person. And so cultural humility is also about being aware of maybe historical references, maybe environmental references, maybe intergenerational references. We have folks who are coming in as asylum seekers. We have folks that are coming in as immigrants, and we have folks who come from different parts of the country and different parts of the world, and all that. Cultural humility really encourages us to elicit that information for that person and include them in their care process. So really, PCC, person-centered care, means treating residents as equal partners in their process of healing. It's more of a personalized approach, and it recognizes the capacities of people with substance use disorder to actively participate in improving their own health. So consider this: anyone who may have a substance use issue, problem, who may not have a disorder, or even someone who does meet the criteria for the disorder. Having that conversation takes sensitivity, takes a very personable approach. It actually encourages you to be able to have a conversation, just a simple conversation without judgment, with respect, with empathy, so that that person is more responsive. Thank you. They're more responsive to you in the conversation. And if they're able to be more comfortable with you and feel safe with you and be able to divulge and share with you very specific issues in their life and their perceptions, you're more likely to be able to engage them in a conversation where you can support them and understand and helping them see how behavior change in terms of their substance use and their healthcare and their care plan can be really um, can be very much the potential for successful outcomes can be very much augmented by that conversation you can have with them. So what I'm going to do here is just go to this slide and just say one of the things that I encourage folks to do is to use open-ended questions. To ask the other person what's going on with them, have them and engage them in such a way where they're more likely to elaborate with you. And we have a longer version of this particular webinar where we go into this a little bit more deeply. And so the affirmations of effective listening and summaries, I'm sure it's something that you folks have been exposed to, and that this is something in practice that can help you be more other person oriented. Here's the things that I would like to leave you with. There's a 4 C's of person-centered care. Care is to integrate the person's perspective, needs, and desires. Care is responsive to what they believe they would like to see, the part that they can play. Culture considers the person's cultural views and capacities and resources. Communication is really how you engage that individual and where that individual can feel that they can have a conversation with you without being judged. And the collaboration is how you can partner with that individual. Yes, you have all the expertise you need, but without their participation, it tends to be less participatory on their part, which is essential to what they can do so they can self-advocate for their own health. And so nursing home residents with substance use, think about how we can engage residents in understanding health issues and the impact that substance use can have. Different levels, even the minimal levels, can have on their health. So you have an opportunity to engage them in a conversation where you provide information. And so, and it's also another opportunity to develop, so for them to be able to consider what are the pros and cons. If they are at a point where maybe they can need some support, they need some substance use resources, you can help them understand what is available and help connect them to it. You want to support their decision in seeking substance use disorder treatment or not. It may not be that they need the treatment. It may be that some supports that you can help access for them can actually help them, like harm reduction options. Even a brief intervention, you folks are in a position where you can have a brief intervention with them. We can support residents to implement resident decisions regarding their substance use and regarding their health care. And overall, part of person-centered care is the ability and the benefit of having someone commit and participate fully in their own wellness process. Actually helps you even better to give them care. And so with that, I wanted to just thank you all for your time and give it back to Nikki.
Thank you very much, Diana, for presenting today's training. Our team truly appreciates you. This information is valuable.